Welcome to EM Talkscast. My name is Rich Hamilton. I'm broadcasting today from the EM Talkscast studios. And I would like to share a talk I did this past week at the Association of Academic Chairs and Emergency Medicine Retreat. The title of the talk is a social media primer for EM chairs, hashtag get on board. And the idea of the talk was to let my fellow chairs know what was going on in social media and sort of bring their attention to it. But I would say perhaps maybe the more important message was to really ask the question, can social media save emergency medicine? Because I think emergency medicine is at a bit of a crossroads and may need some saving. And I think social media is poised to do so. So I like to describe myself as the George Selkirk of emergency medicine because of a couple of different things. George Selkirk played right field for the Yankees, was a very good ball player, won a number of World Series rings in the late 1930s. Although I'm not Canadian, George Selkirk was Canadian. He was called the Mr. Canadian October of baseball in his time. And I liken myself to George Selkirk because George Selkirk is the answer to the trivia question, who played right field after Babe Ruth? And likewise, about 10 plus years ago, I took over the Department of Emergency Medicine at Drexel from one of the legends of emergency medicine, Dave Wagner. And I learned a lot of lessons about emergency medicine from Dave Wagner. Most specifically, that emergency medicine was really about patients and patient care. Dave is still practicing medicine and emergency medicine. He does not work in the emergency department at this point. He has focused the end of his career activities on teaching medical students. And every Friday, Dave heads out to North Philadelphia to the Needle Exchange site and sets up an afternoon clinic where he and lots of students and residents take care of anybody and everybody who needs medical care. So when Dave says emergency medicine was created by patients, he really does mean that. And it's true, emergency medicine was created by patient demand. They wanted someone to care for them 24/7. But the problem we have today is that patient care is becoming so difficult and so burdensome that folks are leaving clinical medicine. And I think I see folks leaving clinical medicine in the beginning and end of their careers. I see senior physicians who are retiring early, because they've just lost one more piece of their autonomy or independence. And I see younger physicians who come into my office trying to carve out career paths that are non-clinical, thinking about MPHs, MBAs, consulting, public policy, etc. Folks are unhappy with medicine. They're not unhappy people, though. The emergency medicine physicians are among the happiest people out there. But as soon as we get to work, we are really, really unhappy. In fact, we're among the unhappiest of doctors in the house of medicine. And so at this point, it's worth it to consider what does make people happy. And Daniel Pink, in his book Drive, said that there were three things that motivate people, that made people want to move forward. And those three things were autonomy, mastery, and purpose. Autonomy, being able to control aspects of your life, especially with regard to work, aspects of your work life. Mastery, getting better at what you do and learning new skills and improving on your skills. And purpose, serving something that you perceive as greater than yourself or your own needs. And I think we're at a moment we can't ignore. And I was really moved by the book Malachi O'Connor and Barry Dornfeld wrote about this, where culture driving strategic change. And they suggested that when problems are afoot, leaders look inside their organizations for what they call found pilots to see how problems can get solved. And a found pilot is a project, practice, or event in which the future is already beginning to show up. And so it's my theory that the social media and medicine folks are the found pilots of emergency medicine and medicine in general, and that what they're doing is restoring a sense of autonomy, purpose, and mastery to the practice of emergency medicine. Now, how do I think they're doing this? Well, there are three main thrusts of social media in healthcare right now. Social media seems to be building social capital. It certainly seems to be accelerating knowledge translation. And it is penetrating and perhaps even creating the personal learning networks of learners and educators. So let's take these one at a time. When it comes to emergency medicine, we are really, truly bowling alone. Robert Putnam wrote when he was trying to dissect the collapse of American community that what he discovered was that what was happening was that the networks of relationships that enabled society to function effectively, which is what he called social capital, were beginning to fall apart. The idea was that we were no longer bowling in leagues and getting together and communicating and working together. We were all coming to the bowling alley and just bowling alone. Social capital is very important for effective functioning. And it was that idea of creating a connectivity and networking that prompted Kay Moody, who is an EM physician, moved by the concern that she had for where the specialty was going, to create the EM Docs Facebook page. Right now, EM Docs Facebook page, last time I checked, had roughly 12,000 members. And on that page, you will see folks sharing and networking about everything and anything in emergency medicine. You'll see posts from Kay talking about how to stay connected when you're having difficult times. You'll see folks putting up difficult EKGs and cases and asking for help and getting it literally within 10, 15, 20 minutes of their post. You'll see folks bragging about how they cleared the board, and you'll see some very upsetting stories about how an EM physician worked for 24 hours, passed away, or somebody was in their car driving after a lot of shifts and was in a car accident. In fact, it was on EM Doc's Facebook page that we first heard what was going on at Summa, well before it was posted on any of the blogs, and well before it got to any of the EM email lists or whatnot. So social media is really building social capital in emergency medicine, and it's creating connectivity and reducing social isolation. This is a very important component of what social media is doing. And although the thrust that we see of social media right now seems to be educational, this is one of the main three things, the main important components of what social media is doing. Now, what about knowledge translation? Well, when I spoke with Ken Milne about this, his theory was that if you looked at Pathman's pipeline, that really what social media was doing was working on the awareness leak between clinically relevant evidence and good bedside practice and good outcomes. And it's true. Social media definitely solves the information overload, difficulties with time and search strategies that most physicians have. And it does provide accessible appraisals and can be delivered automatically, to your ears in a podcast on a regular basis. No question about that. I also think that social media is creating agreement. I see on Twitter especially arguments and counter arguments going back and forth that is creating a sort of uniformity of practice across emergency medicine without having to force people to follow guidelines. And when you understand the international component of social media, you'll see that what retrieval docs are doing in the outback in Australia is influencing greatly what docs are doing in inner city urban teaching hospitals in terms of practicing emergency medicine. So it's definitely creating an agreement as well as that awareness component. So for sure, it's accelerating knowledge translation, and this can be for better, really, truly. If you look at the sepsis guidelines and the speed at which folks are beginning to adopt changes, you'll see that I think a very positive effect. Of course, there's the concern about pure punditry, which is that the power of social media is to give a voice of a particular individual. but it has to be sort of absorbed and read or listened to with a degree of skepticism, I suppose, but also with understanding what the primary source is about and still reading the literature. Now, the other thing that I think is really quite interesting is the ability of social media to help penetrate the personal learning network of learners and perhaps even help build a personal learning network for learners and educators. If you look at the social media movement, the knowledge workers of emergency medicine, the educators, really followed their learners into social media because they realized that penetrating in this personal learning network was the one of the best ways to make sure that they were teaching their students where they found them. And a personal learning network, is very diverse. You learn things from meeting people and sharing knowledge and problem solving. And it has a great influence on your practice. In fact, there is literature that suggests that residents within a residency who work more shifts together will end up with similar practice styles at the end of their training program. So it is not a small effect. And so a personal learning network is sort of like a life hack. And you can create a self-directed, self-regulated learning plan and work towards mastery with this network. And social media helps educators penetrate into those learning networks, number one. And number two, helps learners create their networks of educators that they feel they really get a tremendous amount from. And just to talk about influence of social media, there are 34,000 or so members of ACEP. A little bit fewer actually have a subscription to Annals. Who knows how many actually read it? And if you start looking at the folks out there who are producing social media, you'll see that their influence on folks really begins to match what the influence of the big societies, in some cases exceeds the influences of the big societies in emergency medicine. So penetrating and being part of a personal learning network is huge, and we're definitely seeing that effect with folks on social media. In fact, it is almost a given that a resident nowadays will be as greatly influenced by some of his faculty as somebody outside of his own residency. Now, this little infographic I created, but I just want to show how healthcare Twitter accounts really took off in 2008 and have been climbing steadily ever since. Only a third of healthcare Twitter accounts are in the U.S., so it is definitely a very international phenomenon. And in case you're wondering, patients are not that uncomfortable with it. Most patients would be comfortable or very comfortable with an online community helping their doctor. A quarter don't care. But do realize that roughly a quarter would be actually fairly uncomfortable or very uncomfortable with the idea. So it's not 100% embraced, but still fairly well accepted. So for chairs, the question was, if you're not convinced that social media has a role in healthcare and might be actually creating a better, environment and helping folks with their mastery, their purpose, and their sense of autonomy, then ask yourself this question: who's determining your brand? I would suspect that for the learner in the 28 to 38 age bracket, the social media folks in your department are creating your brand. The learners and the educators are definitely grouping together on social media. And so if you are publishing a paper and you don't have a social media presence, your knowledge translation time will be longer than if you do, for sure. Chairs really need to look at how they value social media for promotion. And in particular, I think the tools are definitely there now for looking at altmetrics and other impact factors to determine the value of basic research and the publications. but also then valuing the contribution of free open access med education and other efforts to the education that's out there. If one single FOAMed producer can have as many followers as the Society of Academic Emergency Medicine, you would really be remiss if you didn't value that impact. The other thing I think chairs really need to do is to find out what's already being shared. And so since a great majority of chairs have no social media presence whatsoever, and a good number of them have no connectivity whatever on social media, one of the main recommendations I make to all the chairs is to say, get a professional Twitter account and at least follow the conversation, even if you don't need to or feel any interest in generating content. Get on the EM Docs Facebook group and see what folks are saying and listen to the conversation going on there, so that you can already have an idea. Get a social media policy if your organization does not have one. Talk to your faculty about social media and what's being shared, and make sure that everything is HIPAA done within HIPAA and being done appropriately. And the last question is, what are the concerns? And there are many. Social media is a funny thing. There is some evidence that engagement in social media can have the reverse effect and create a sense of isolation. And I have seen a number of times where folks who are engaged in social media often feel like their compatriots have a much better or much more exciting practice than they do because they keep posting all these interesting cases. So plenty of concerns about social media. I guess the old saying, if you don't want to see it on a billboard on the highway, don't post it on your Twitter account. But chairs need to be very much aware of all that. So what was my to-do list for the chairs? Well, what I said was that I felt that there was a role for the Association Academic Chairs and for individual chairs in social media. And I would divide it into three areas. One, I think chairs need to start understanding how to generate content and look at the content that the department is generating and make a contribution there. And even as an individual chair, if you're not interested in generating content, look at what your faculty are doing and measure the effect and value it for promotion. I think the second thing is that it's important to create community. And while it may be easy to try to be competitive and see how many followers you can get, I can tell you that I personally created my Twitter account and my board prep account, etc., just to get 15 new Twitter followers a year, and that is to get my interns and residents and to create a learning network for them that extended beyond the shifts that I did or the time I spent in conference. So community can be as small as or as big as you would like it to be. And then the other thing is to provide a context. What does social media, how does it fit into your career as an EM physician and as an academician and as a person, and how engaging in social media will bring positives and negatives that need to be managed and considered overall. So that was my talk, and I hope you enjoyed it. And I would love to hear your comments about it. And I do think that social media is really bringing this sense of autonomy, mastery, and purpose to the practice of emergency medicine. And I'm excited to see where it goes from here. So thanks, and we will talk to you soon.